Okay, folks, let's go over chapter 12, which is a skeletal system. We're going to talk about the function of the skeletal system. This is the overview at the very beginning. Describe long bone and the types of tissues it has, and the three types of cartilage that we have in the body. That's going to be the hyaline, the elastic, and the really tough fibrocartilage that you have in between your vertebral discs, for example. Anyway, so let's move on. The skeletal system has two things, bone and cartilage. We might as well point out that it starts out as cartilage that is then replaced by bone as a baby is growing in the womb. Ligaments are fibrous connective tissue that you can see here join the bones. Totally true. The way I always say it when I'm trying to emphasize this to students, ligaments, the L should remind you that they link bones together. Tendons, the T should remind you that tendons tie muscles to bone. So tendons tie muscles to bone, ligaments link bones together. With that in mind, let's move on. All right, we're going over the functions of the skeleton. It supports the body. What we're talking about is your long bones are what your muscles are attached to. The bones of the skeleton are what hold you upright, okay? Or I should say the muscles hold you upright by pulling on the bones. Anyway, this also is how we move the body, muscles pulling on the bones. Also, there's protection. So we have support, we have movement, or working with the muscles movement. We have protection. The skull protects the brain, the ribcage protects the hearts and lungs, the vertebrae protect the spinal cord. Pretty straightforward. They're not mentioning it here, but you have some important organs in your pelvis. Those are at least partially protected. The bones are where we make red blood cells, where we make all blood cells. And that obviously is super important because your average red blood cell is only going to last, I'd have to look it up, but I think 20 days. Hold on, I am going to look it up. Okay, I checked and I was wrong. It's not 20 days, it's 120 days. Actually, 115 to 120 days. That's about the lifespan of a red blood cell. Anyway, so my point remains that you have to produce lots of blood cells. That's really important. And that happens in your skeleton. So another job of the bones. The bones are also a place that you store minerals and fat. The yellow bone marrow is actually full of fat. All right, let's move on. So the anatomy of a long bone, I'm talking about like your leg bones, your femur, your tibia, your fibula, your humerus in your arm, your radius and ulna in your arm. The main shaft of the bone, the long portion of the bone, is the diaphysis. And the two ends, both the proximal end and the distal end, those are the epiphyses or single epiphysis, all right? So the diaphysis, the shaft of the bone, it's hollow inside and has a medullary cavity. You actually, we'll talk about spongy and compact bone later. The spongy bone has marrow in it also. But what we're talking about right now is that shaft of bone, it's hollow inside and filled with bone marrow, okay? So the medullary cavity in the diaphysis, compact bone walls, hollow in the middle. It's lined on the outside. The book hasn't said this yet, but bones are lined on the outside in a periosteum. It's a membranous layer. And on the inside lined with the endosteum. And the space in the middle between the layers of endosteum, or the space inside the endosteum, is filled with yellow marrow, which is fat. That's why things like a hyena will break open bones to get the energy inside. Anyway, the epiphyses, the long ends, the ends of the long bone, um, they have red marrow and they're spongy bone. Instead of being hollow inside, they still have compact bone on the outside, but it's a thinner layer than on the shaft, on the diaphysis. The epiphysis has a thin layer on each end, and then inside of it, instead of a hollow cavity, it has it looks like a sponge. That's why they call it spongy bone. It's got little trabecula, which are like spicules, little pieces, girders going in different directions, and the holes between them are filled with bone marrow, red bone marrow, and that's where the blood cells are actually produced. That's where we do the fancy word would be hematopoiesis, the making of the red blood cells. All right, so there's a pretty picture. You can see the shaft, the diaphysis. You can see the end, the epiphysis. The metaphysis is another name for the transition between the two. We haven't talked about it yet, but you'll notice that there's an epiphyseal line there. That's where the growth plate was. As long as that growth plate is cartilage, the bones are going to keep growing longer. But you have kind of a race going on between cells making cartilage and cells turning that cartilage to bone. If they use up all the cartilage, you're done growing. That's probably going to happen around age 25, maybe. Anyway, you can see the medullary cavity, the middle, that's where the bone marrow is. You have compact bone around that. You have the endosteum inside of the compact bone and around the marrow. You have the periosteum, the membranous layer, and it's fibrous and tough. It's not like, oh, this delicate membrane, like a cell membrane. The periosteum, it also has cells in it that can generate bone. We call that appositional growth, where you make it thicker by adding to the diaphysis, adding to the side of it. But we'll talk about that later. Anyway, the epiphyses have a thin layer of hyaline cartilage. That's because they articulate. You have a joint, and you have one bone and another bone rubbing on each other, rubbing on the ends. You don't want bone rubbing on bone. That's super nasty, painful. Instead, the end of each one is cartilage. So we have a joint, and we have the hyaline cartilage where they articulate, where they rub against each other. Actually, this whole thing is probably going to be in a joint capsule that has synovial fluid to help lubricate the movement. So it's not just smooth, slippery cartilage on smooth, slippery cartilage. You even will have a little bit of sealed lubrication in there. The epiphyseal plate is where cartilage is. I already told you. The metaphysis is between the epiphysis and the diaphysis. And inside of that, the epiphyseal plate, which that's the growth plate. And you already know, we already said it, when that fills up with, when the cartilage there is replaced by bone, you're done growing. That bone doesn't get longer. Now the periosteum, that's the connective tissue covering the bone. That's what is stuck to the ligaments and tendons. The connective tissue of the ligaments, connective tissue of the periosteum, they grow together. They're continuous. The connective tissue of the tendon, connective tissue of the periosteum, same thing. The fibers are intermingled, and it's really hard to tell where one starts and the other ends. This is good. This is how we attach muscle to bone. So two types of bone, we already mentioned both of them, compact and spongy. Compact is super organized, really tough. It has these long tubular things that go along the shaft of the bone called osteons. And each osteon, if you take it and cut across it, and then look, it has a central canal. They used to call those Haversian canals. I don't know why they changed it. But that central canal is going to have nerves and blood vessels in it. And then around that, you have rings going out. Just like you cut an onion, you see rings in the onion. you have rings going out of bone material. And bone material is both the hydroxyapatite, that's the mineral that has the calcium and the phosphate, and lots and lots of collagen fibers, lots of fibers. Between the rings, you'll have areas where there's a widened space that's called a lacunae, which is a little lake. That's where the word comes from. But what it means is it's a spot where you have a cell, an osteocyte living. That's a mature bone cell. They're involved in detecting stress on the bone. Between the lacunae, you're going to have little canals, teeny canals. We call them canaliculi, which means the little canal. And that allows the different osteocytes to communicate with each other. Okay. And the matrix is the space between the rows of lacunae. They're talking about those layers that are in rings. That's the stuff that has that hydroxyapatite in it. Here we have a nice picture, and you can see that we have an osteon, and it has circular layers. There's a central canal, a reversion canal, all the stuff we were just talking about. This tough, dense material with all the bone, that is what makes up the wall here of the diaphysis. Okay, a compact bone is also what you have around the epiphyses right here. Okay, spongy bone is what you have on the ends of the bone. Both sides of the growth plate, you have some spongy bone going on. And spongy bone, remember, is more likely to have red marrow than yellow marrow, especially in the adult. Let's move on. So in this compact bone, you have tiny canals called canaliculi. They connect the lacunae to each other and with the central canal. It lets the osteocytes exchange nutrients and waste that get to the central canal through little gap junctions. What we're saying is that those osteocytes living in the lacunae, they have connections to the other ones and holes that pass between the membranes, so they can exchange chemicals. All right, so trabecular bone has a bunch of, spongy bone is a bunch of little plates are called trabecula. Think of them as girders going in different directions. It is lighter than compact bone because it's not solid, but it still is designed for strength. The trabecula are often, now I can't personally see this, I have to trust them, but they say that the direction of the trabecula actually lines up along stress lines in the bone to make the bone stronger. Red bone marrow is what we have in the spongy bones. It makes all the different types of blood cells. We've talked about blood cells before. So you know I'm talking about erythrocytes. I'm talking about the megakaryocytes that split apart to make our platelets, our thrombocytes. And I'm talking about the neutrophils, lymphocytes, monocytes, which grow up to be macrophages. Monkeys eat eosinophils and basophils. Okay, so osteocytes in the spongy bone, they're in the spaces between the trabecula. Nobody's surprised with that. It's not saying it here, but the trabecula are also lined in endosteum, in that same membrane that lines the shaft of the diaphysis. All right, we've talked about bone. Let's talk cartilage. Cartilage is not as strong as bone, but it's more flexible. The matrix has, I'm talking about the space between the cells, has lots of collagen, lots of elastic fibers. Just like in the bones, we call the bone cells osteocytes. We're calling the cartilage cells chondrocytes. and they are in lacunae the same way. Cartilage doesn't have nerves, blood vessels, things like that, and it gets it gets nutrients from the stuff around it. That makes it super hard to heal, and I'll add to that, super difficult at recovering from an infection. If you get an infection and you've got almost no blood flow, you've got almost no way to deliver white blood cells into the infection. That's why doctors totally freak out about joint capsule infections, cartilage infections. Hold on a sec. Okay, I'm back. What I did is I pulled up a article in the Journal of the American Medical Association notes where they were talking about an incident that happened, I think, in Oregon, but with a piercing pagoda, where a Pseudomonas infection got spread from person to person in cartilage in ear piercing. You know, people who have a cart pierce where they pierce the cartilage, and the problem was that the disinfectant solution they used actually had a microbe living in it. There are some microbes, Pseudomonas being one of them, that are so virulent, they're so good at surviving, they can take disinfectant solution that kills other bacteria, and they can break it down and use it for food. And anyway, this nasty bacteria got into a bunch of people's ears through misuse of disinfectant solution at a piercing pagoda. And because some of them were getting cartilage pierces, it would digest the cartilage in their ear, specifically Pseudomonas will release a chemical called collagenase that breaks down collagen and kind of liquefies the ear and turns into jello or jelly. And they needed reconstructive surgery. And the reason I brought that up was, if this infection had been in a tissue that had adequate blood supply, a decent amount of blood supply, you could have delivered a whole bunch of white blood cells to the site to kill the bacteria. But because it was in cartilage, it was really hard for the body to fight. And some people needed reconstructive surgery because of it. Anyway, moving on. So your book wasn't kidding when it said, oh, that makes it slow to heal. All right, there are 3 types of cartilage. Hyaline cartilage, that's what you have here in your nose. That's what your entire skeletal system is when you are a fetus inside the mommy, and your before that is replaced with bone, remodeled and everything. Hyaline cartilage is what it's made out of. Fibrocartilage is that tough, gritty, really resistant cartilage that you have between your vertebral discs. Elastic cartilage, it's it has a lot more elastin fibers than normal cartilage, and your outer ear is made of it. That's why you can fold it over and twist it around and it'll bounce right back with no damage. All right, so let's move on. Locations of cartilage. Hyaline cartilage, the end of your long bones, your nose, the end of the ribs, the larynx and the trachea. I forgot to mention that. Fibrocartilage between the vertebral discs and in the knee. That's because your knees have serious impact resistance. It's still possible to destroy them, think jogging. But yeah, fibrocartilage is where you have to resist vertical forces smashing bones together. Elastic cartilage, I talked about the ear flap. I should have mentioned the epiglottis. Every time you swallow, there is so say here's the opening into the windpipe, into the trachea. And we call that opening the glottis. We have sticking up above it the epiglottis. Epi means above. This whole thing is lifted up when you swallow. When it's lifted up, the epiglottis, it pushes against things above it, and that causes it to bend down, covering the hole so you don't get things in your trachea. And then when you're done swallowing, everything pops back. So that means every single time you swallow, which you use so many times every day, this cartilage has to flex and pop back, flex and pop back, flex and pop back. So the epiglottis is also made of elastic cartilage. All right, let's move on. Fibrous connective tissue is made out of fibroblast. It has lots of rows of fibroblasts separated by collagen. All right. Fibroblast, the blast has a B in it, and that B should remind you that they are baby cells. They're going to grow up to be other things, but the B should also remind you of the word build, because these help build things. Okay, the fibroblast, it says here, the fibrous connective tissue with the fibroblasts living in it. Um, this is the tissue that makes up your ligaments and your tendons that hook your ligaments to each end to a bone. Remember, ligaments link bones together. Your book there, it doesn't sound quite as poetic, but your book says ligaments connect bone to bone. All true, just not a stylish way to say it. I prefer a mnemonic that helps you. So ligaments link bones together. Tendons tie muscles to bone. Where it says tendons connect a muscle to bone at a joint, at an articulation. Tendons tie muscles to bone. All right, let's move on. Oh, it's your first check your progress. So I'm going to be quiet for a second, and you can pause this. You can check yourself, make sure you can answer those questions. If you can't, leave the video, rewind the video, watch that section again. All right, let's do 12-2. Let's talk about the bones of the axial skeleton. So we're going to do bones of the skull, the hyoid. Those are the ones right here in the throat. Whenever you're swallowing, we got muscles attached to the hyoid bone that help lift everything. The vertebral column, we'll talk about different types of vertebrae, I'm sure, and the rib cage. All right. And yeah, so right there, next thing, talk about different regions of the vertebral column. You can tell based on what size the spinous process is, say, what angle it is, things like that. Those can help you tell when you pick up a vertebrae where in the back it came from. I'll also talk about the function of sinuses and intervertebral discs. I'll tell you right now, sinuses are the spaces in the bone, and they can lighten the bone, and because they tend to be lined in epithelial tissue, they can warm and moisten the air. All super important. Like when you're breathing in, you want that air warmed and moistened before it hits the lungs. Okay, an intervertebral disc, shock. Absorb shock, resist shock. We do stupid things to our backbone. It helps them survive. Moving on. You don't want the bodies of the vertebrae smashing together. All right, so we've got 206 bones in the skeleton that are either axial or appendicular. Axial means they're down that center axis of the body. The skull, the neck, the rib cage, the vertebrae, the pelvis, okay, the sacrum. The other, and hyoid bone there too. The appendicular are just like in a book, they have the appendices. The appendix is the thing you add on. Well, it's sort of like, here is us, and oh, we added on the arms and the legs. So the parts of the arms, legs, the hands, the feet, that's your appendicular skeleton. All right. So if we look here at the axial skeleton, it's naming bones of the skull, and we'll definitely want to know things like that. The rib cage, well, let's go over these. So the frontal bone is right here in front. Pretend to be shocked by that, okay? Your parietal bone is going to be there, your temporal bone, and let's see, master process of temporal. Actually, temporal will be, this is so much easier. Okay, so frontal bone, temporal bone, parietal bone. I know we're like, oh, this is the temple. Not really. With a spot right there, most people point to is the temple. That's not it. Okay, occipital, that's the back. And you'll find that we have parts of the brain with similar names in some cases to the bone that covers them. So the occipital bone covers the occipital lobe of the brain. That's where we process sight. I know it sounds odd because the eyes are at the front, but it is what it is. Okay, the vertebral column, that's all the vertebrae that make up the spine. The rib cage, we have the individual ribs. Not all the ribs attach directly to the sternum. Sternum is your breastbone. Some of them attach to cartilage that attaches to the sternum. And costal is the anatomy word for rib. So costal cartilages, these are cartilages of ribs. All right. Anyway, let's move on. The stuff in blue, I guess is what I should say. On figure 12.3, the stuff in blue is axial skeleton. All right, so the skull is the cranium. I'm talking about the brain case, the stuff that holds the brain, and the facial bones. Okay, so the cranium protects the brain. In adults, we're talking 8 bones. Babies have soft spots in the skull. We call those fontanelles, and those stay membrane until after birth. And the reason for that is the birth canal is narrow, but the skull can flex. It can bend a little bit, not a huge amount, but we can change its shape to fit through that narrow birth canal a little bit. The fontanelles are going to close, meaning the soft spots fill up with bone, by about 16 months. All right, 16 months after birth. All right. The cranium, our bones, frontal, parietal, occipital, temporal, sphenoid, and ethmoid. All right. The frontal in front, the parietal, the occipital, the temporal. Here, let's do this again. Okay, let's try it like this. The frontal, the parietal, the temporal, the occipital. Now, you might say, why not sphenoid and ethmoid? Actually, sphenoid does show a little bit here. Those would be the wings of the sphenoid. The sphenoid is kind of butterfly shaped, and it makes the bottom of the brain case. And but the end of the wings will actually, it sticks out on the side. You can see it right there. Anyway, and the ethmoid, the ethmoid is famous because it has this big sinus in it, the ethmoid sinus. I shouldn't say big, it has an ethmoid sinus in it. The hole that the spinal column comes in, the brainstem comes out, that's the foramen magnum. Magnum, like big, huge. Since I'm done poking at my head, I'm going to plug the headset back in. All right. So magnum means big. Foramen means hole. Literally, foramen magnum is, oh, that big hole in the skull. It's the one at the back the spinal cord comes through. Now, the external auditory canal. In olden days, we called it the external auditory meatus. It is the hole that sound comes in. It's part of the temporal bone, which means it's down low here, okay? I know when you think of the temple, like, oh, somebody got punched in the temple, you're thinking of up here. Well, that's sphenoid. The temporal bone is straight in there because that hole goes right in it. All right, the sphenoid completes the sides of the skull and contributes to forming the eye sockets. The ethmoid also does the same, and the nasal septum. So if you stuck a finger in each nostril, I know that's gross, and follow it back, further than you really want to, when it stops feeling like cartilage, it feels like bone, that's going to be ethmoid. And remember, you have a sinus there too. All right, so here we have our bones. and you can see frontal bone. I'm going to do that again. You can see the frontal bone, the parietal bones. Below that, your temporal bones, your occipital bone there. And if you feel right here, right behind that ridge, that is the end of the wing of the sphenoid. I'm going to jump ahead and find another picture of the sphenoid for you. Are we going to do this or not? How can you not have a picture from the inside of the skull? That's so sad. Hold on, pause. I will find a picture of a sphenoid bone from the inside. Okay, folks, here we have the sphenoid bone, and you can see that it's part of the bottom of the brain case. This really isn't showing as well as I want to. We'll do that on the next one. But this side view shows really well what I was saying, where some people talk about, oh, I hit my temple, I got punched in the temple, whatever. They're actually probably talking about the outer edge of the sphenoid bone, where the book said, oh, the sphenoid bone helps make up the eye socket. Yeah, the back of the eye socket there. You can see it pretty good from underneath the skull. It's the bottom of the brain case. It's holding the brain from underneath, bottom of the cranium. The little bit of it barely peeks up there. Let me go over here and show you. There you go. So here's the little wing of the sphenoid on the side. But look inside the skull where the brain sits. A huge chunk of the floor of the cranium, floor of the brain case, is this sphenoid bone. And not that you care, but we'll go ahead and talk about here. This is going to be ethmoid bone sticking up. And there's a spot on there called the cribriform plate of the ethmoid bone that's sort of famous. This bone is, the texturing you see there, it's got holes, and that's where your olfactory nerves are sitting. Anyway, but let's move on. This is the huge foramen magnum, the big hole that your spinal cord comes through. All right, so let's move on. Let me pause this. Okay, so here we are. It mentions the sphenoid. It doesn't have a good picture of it there. The sphenoid completes the sides of the skull, contributes to forming the back of the eye sockets. The ethmoid has that helps with the form, the orbits, where the eye goes, and the nasal septum. If you think about it, where I said, oh, stick your finger up more than you want to and feel where it's not wiggly or it's bone, since the olfactory nerves sit right on top of it, that bone, it makes perfect sense. They're held apart by a part that sticks up called the, I think the crista galli is the name. We'll find it. I'm sure it'll be on a slide coming up, but it's like a sailboat sail that sticks up, and it keeps the olfactory nerves and the olfactory bulbs separate from each other. Anyway, let's move on. So there we have our skull. You know that you need to know the frontal bone, the parietal bones, the temporal bones, and the occipital bones. That's your cranium. We'll talk about the mandible and the maxilla and the palatine bones and the nasal bones and all. We're getting to that, the lacrimal bones. All right, so your palate, when we talk about a palate, we're talking about the roof of the mouth, okay? The bones that separate the nasal cavity from the oral cavity. And the ones in the front are the maxilla, the ones behind those are the palatine bones. And they've got a hole there. Now your cheekbones here is part zygomatic bone and part zygomatic process of the temporal bone. So, but you have this ridge right here that sticks out more in men than women. That's one of the ways that we tell a male skull from a female skull. But this ridge right here, this thing, it also, if you think about it, helps protect the eye. If a fist comes in towards the eye, it's probably not going to be able to hit the eye as hard if it is, because it'll probably hit this bone too. Not always. If it hits this bone too, it can't go in as far, can't squish the eye as badly. So think of the zygomatic arc, which is made out of the zygomatic bone and the temporal bone. Think of it as a protective thing. All right. So the maxilla and the maxillary bones and the palatine bones, those are the hard palate. In back, we don't have holes that go through like this. The holes are in the bone, but you have flesh, you have tissue that goes back there. If you put your finger here, you'll feel eventually, before you get to the very back, it feels soft. That's because you have flesh there, but no bone, and that's the soft palate. So hard palate is these bones, then you have the holes, and the holes, because of the tissue, are considered to be the soft palate. They still divide the nasal cavities from the oral cavities. All right, let's move on. So the frontal bone, you've got that. The temporal bone, you have that. We talked about that. Understand that goes down to underneath. Let's actually deal with the face. All of this, that's maxilla. Above that is nasal. But we also have, look at these little blue, these are lacrimal. Lacrimal means tears. Your tear ducts go through there. And the ability to drain tears away into the throat, also through there. And I want to double check that. Hold on. Okay, so I just pulled up Wiki to check, and yes, the lacrimal bone is responsible both for the tears being released into the eye and tears draining away from the eye. They drain into the lacrimal sac, and from there they go down into the throat, where we talk about someone having a runny nose when they're crying. Anyway, so I just wanted to be sure I was saying the right thing. Didn't want to steer you wrong. Hold on. Okay, back to our PowerPoint for your book. I want you to know that the maxilla is the upper jaw and the mandible is the lower jaw. And in a fetus, these actually grow as separate bones on the two sides, and they fuse at the mandibular symphysis. All right, let's move on. All right, so sinuses are air spaces, and they're lined in mucous membrane, mucosa. Because there are these holes, these spaces in the skull, they make the skull weigh less, and they also are spaces that the air bounces around in when you speak. Part of the sound of your voice is from air reverberating inside the sinuses. Your frontal sinus is right here. It's in the frontal bone. On us, we have bone on both sides. On some animals, where lightening the skull is super, super important, reducing weight is ultra important. Like an elephant, they only have one of the two bones on the skull. Well, we can talk about that later if you want. A famous hunter named Karamojo Bell took advantage of that. Anyway, so frontal bone, there's a frontal sinus. Sphenoid, it's inside, and well, it's on the picture I showed you before. You can see it from the side. You know, that sphenoid bone that forms the bottom of the brain cavity continues down, and there's a space inside of it in back of the throat. Ethmoid sinus, you have a space inside the ethmoid bone. The maxillary sinuses are in your maxilla, obviously. We're talking upper here. If you get what's called a squeeze or a reverse squeeze when you're scuba diving, highly don't recommend that. Do not dive when you have congestion, because you can get a maxillary squeeze. It feels like someone is breaking your upper jaw. It's bad. Been there, done that. Don't ever want to do it again. There's another sinus that they are, there we go, the mastoid sinuses in the middle ear. These are in the mastoid process of the skull. I'm going to jump back in the PowerPoints a little bit. All right. And it's not labeled in this picture, but this bulge that's right there, part of the temporal bone that's sticking down, that is your mastoid process. It's hollow inside. And the mastoid sinus is the space inside of the mastoid process. All right. They may have labeled it here. Nope, doesn't look like they did. All right, let's move on. So inflammation of the mastoid sinus is mastoiditis, because itis means inflammation. Let's move on. So the bones of your face, the mandible, that's your jawbone. The maxilla, that's your upper jawbone. I should have said mandible, lower jawbone. Your zygomatic bones. This is the zygomatic arc, and the zygomatic bones that are on the front of the face and can start that arc, those are main bones in the face. And the zygomatic arc is finished by temporal bone, zygomatic process of the temporal bone. Anyway, let's back up so you can see the zygomatic, see the mastoid right here. Here we have the, why did I say mastoid? Maxilla. Here you have the maxilla. You can see how it's not just the upper jaw, it's this huge piece of the face. And then this green, this is your zygomatic bone or zygomaticus. It's part of the eye socket. It's the beginning of this ridge that protects the eye that we were talking about. When you go, zygomatic bone right there, continues, and back here we have temporal bone. So this is the zygomatic process of the temporal bone, and this is the zygomatic bone. All right, moving on. All right, the mandible is the movable portion of the skull. We're talking about your lower jaw that can move. The maxilla is the upper jaw and part of the eyes, the orbits. The hard palate, we already talked about this. It's the top of the mouth and the floor of the nose. It's the maxillary bones, the maxilla, and the palatine bones behind that. And the soft palate is behind the hard palate. That's where those holes are, where there's no bone. Zygomatic bones form the cheekbones. I'm going to point out, you just saw a moment ago, part of the cheekbones. The cheekbones continue with the zygomatic process of the temporal bone. Moving on. All right. So the mandible, lower jaw, maxilla, upper jaw, zygomatic bones and nasal bones, those are the ones we're talking about. Nasal bones, like you look at your nose, this is cartilage, wiggle all the way up until there's no wiggle. That's where the nasal bones are, way up there, okay? And behind that, other bones, ethmoid and vomer, they're part of the divider, the septum in the nose, which divides it into two. I already told you the ethmoid bone, it's perforated, it has holes, and scent molecules go up to the olfactory bulbs that are up there. Anyway, the lacrimal bone contains openings for the nasolacrimal canal, which drains tears from the eyes to the nose. We talked about that. I stopped and looked it up to show you. I probably should have just continued because it says it right here. But anyway, you got to see the pretty pictures and we got to talk about it. The hyoid bone, this is in your throat. This is the top of the larynx, voice box, or top of the larynx. Okay, it is the only bone in the body that doesn't articulate with another bone. The hyoid bone is where you attach the base of your tongue, the back of your tongue, and where you attach muscles associated with swallowing. Those muscles pull and raise your entire larynx, but especially if you put your hand right here, it's on the laryngeal prominence of the thyroid cartilage, and that big shield-shaped thyroid cartilage. Every time you swallow, you can see it goes up. All right. In cases of suspicious death, they look for a fractured hyoid bone. That could be caused by being strangled. Break the hyoid bone. All right, so there's your hyoid bone. There's your larynx underneath it. All right, the vertebral column. We're still in axial skeleton. We're now doing vertebral column. The vertebral column consists of 33 different vertebrae. There are 4 curves that overall they form a upright posture. If you have abnormal curvature to the side, that's scoliosis. If you have abnormal curvature that causes your back to be like that, that is with your pelvis forward and your shoulders forward and the back arched, that's kyphosis or hunchback. If you have lordosis or swayback, that's when your pelvis is tipped back and your shoulders are tipped back and your stomach is pushed forward. That's lordosis. The center of the vertebral column is the vertebral canal. The spine goes through the vertebral canal, and that it's protected by the bones that go around it. There are holes between the vertebrae as you go down. And those are called intervertebral foramina. Again, a foramen is a hole, just like we talked about the foramen magnum, the big hole. The spinal nerves go out these holes, okay? Spinal nerves control your skeletal muscles, whether they can contract or not. If you damage the spinal cord or the spinal nerves, you could have paralysis, you could have death. One way that could happen is if you paralyze the diaphragm and then you can't breathe. If you destroy the nerves that cause the breathing, cause the diaphragm to move. All right. When you look at the backbone, at the vertebral column, many of those bones have a part called a spinous process that sticks up. Almost all of them have a part that sticks, I said up, but it sticks further to the posterior, further back, okay? Then you have the transverse processes that go to the side. So one towards each side of you. The spinous processes are going to go like that. They're like that. The transverse processes are going to go that. These are where we attach the muscles, like the longissimus, to help keep the spine vertical. We're using muscle tension. All right, so we're going to go over types of vertebrae. There are cervical vertebrae. Those are neck vertebrae. Here's a picture. The ones up there are neck vertebrae, okay? And then we're going to have thoracic vertebrae, and then we'll have lumbar vertebrae, and then we'll have the sacrum. But we'll go over these. The first 2 cervical vertebrae are special, the atlas and the axis, all right? Okay, here we have a big famous statue, all right? This is Atlas. He was one of the Greek titans. Let's make this a bigger picture. Oh, mildly bigger. Okay, too big. But here's Atlas, and he was the titan who carried the whole world. That's him carrying the world on his back, all right? So why am I bringing that up? Because if you think of that world as a big round cranium, like with a brain inside, what I'm saying is there is a bone, a special cervical vertebrae that we call the atlas. And it's the one that rests right against the skull, carries the skull. All right, your atlas carries the skull, and the atlas is the only one of those cervical vertebrae that's going to turn with the skull when you turn its head, when you turn your head. So the atlas turns with the skull. It turns, it pivots on the axis. It might help you think of an axle of a car where the wheels go round and round. Well, the axis vertebrae, the second vertebrae, the atlas and the skull turn round and round it. It has a little part that sticks up that they call a dens. And well, let me go back to the picture. It'll be easier. Hold on. Okay, so here's a much better picture. This is still from Wiki, but notice the atlas is this circular shaped, roughly, bone that supports the skull. It holds the skull. And I want to point out some other features. You have the transverse processes that stick off to the side, and each one of those has a little hole in it. That hole, this hole right here, is the vertebral foramina. Okay, that's a hole for the vertebral artery, named because it runs through the cervical vertebrae, goes up. Those are two that go up, and then they're going to fuse into the basilar artery. The basilar artery is one of the ones that feeds the brain blood. It brings blood to the brain in a thing called a circle of Willis. The circle of Willis allows you to have multiple ways of getting blood to the brain, and if one of those vessels gets blocked, other ones will work. So you can still deliver blood through this vertebral artery, through that vertebral artery. You could deliver it through the carotid artery on either side. All of those go up to this circle of Willis. This supply blood to the base of the brain. Anyway, but this atlas supports the skull, and when the skull moves, the atlas moves with it. What it pivots on is this little thing sticking up here called the dens. The dens is a piece of the axis that things rotate around. So they literally named the vertebra the axis. So here we have the axis, and you can see the sticky up part right here, the dens. It sticks up there, and you might say, well, how could that rotate? How could the atlas rotate around it? Well, the answer is that you have a little ligament that goes across there. So the dens is sticking up in a hole that is bone, 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 ligament going across from one side to the other. And I'm just going to quote this right here. The atlas's chief peculiarity is it has no body, ring-like, blah, blah, blah. Okay. Where is it? There we go. The line above that I was reading. This is what I was looking for. The dens, remember that's the sticky uppy part that's part of the axis. The dens acts as a pivot that allows the atlas and the attached skull to rotate on the axis side to side. So that's important. The atlas holds the skull and it rotates on the dens of the axis. I want you guys to know that. All right. So let's move on, go back to your book. Okay, so I already talked about many of these features. I want you to know the neck vertebrae are cervical vertebrae. You've got 7 of those. The thoracic vertebrae are the ones in the thorax, the rib cage, and the upper back. Those are 12 thoracic vertebrae. Below that, we have the lumbar vertebrae. Those are the lower back. We have vertebrae that are all fused together inside the pelvis, where you have all those fused together. That's called the sacrum. And then below that, we have another 4 that are fused together separately from the cervix. Those are the coccyx. Together, we call those the tailbone. Now, we already talked about the fact that sticking towards the posterior, I would say dorsally, but the whole thing here we're looking at is the backbone, so that makes it hard, but sticking to the posterior, we have these spinous processes that stick up. And I wanted you to notice there isn't one on the axis. So the axis doesn't have one, the others here do. Here we have thoracic vertebra, and they have a facet that the rib rubs on. Obviously, we don't have that where we don't have ribs. The space in between the processes of the vertebrae, you can see how the spinous process points very down in the thoracic vertebrae. It's not just posterior, it's posterior and inferior. And then you have the transverse processes pointing upward, and there's a hole in between. Those holes are the intervertebral foramina. Those are where your spinal nerves come out of. Anyway, let's move on. So spinous process, transverse process, and these transverse processes, you have a superior upward articular facet for the vertebrae above it, and an inferior for the one below it. But we'll talk about that. Anyway, and these on the side where the body is, those are articular facets for a rib. That's a place where a rib articulates. All right, intervertebral discs. We already said these are made out of fibrocartilage. Tough, gritty stuff, very resistant to impact. These have to absorb all the shock of running, jumping, walking. Let me give you an extreme example. Okay, check this out. This is a move in a kayak called a boof. And you can probably tell from that that he's taking a lot of damage on his fibrocartilage and his intervertebral discs. He's landing pretty much on his butt, and the entire shock of that drop is going on his spine. Okay, so these intervertebral discs are made out of fibrocartilage. They prevent the bodies of the vertebrae from grinding against each other. They absorb shock. And because they are tough and gritty around the outside and they're more cushy on the inside, they can allow the vertebrae to bend as we move forward side to side. What we're actually doing is squishing the vertebrae on one side, squishing the intervertebral disc on one side, where we're narrowing, bringing the bodies together, and on the other side, it's bulging out a little bit. Anyway, so. The rib cage is the thoracic vertebra, the ribs, and the costal cartilages, and the sternum or breastbone. It's part of the axial skeleton. It protects the heart, the lungs, the trachea, the lower trachea and the bronchi where they go into the lungs. It says it swings upward and outward on inspiration. This makes sense if you think about it. If you are having your rib cage come up and out, the out is increasing the volume, which lowers the pressure. And so you increase the volume, lower the pressure, air will rush in. Then when you're exhaling, they are moving, the ribs are moving inward and downward. You're squeezing the air out. What you're doing is increasing pressure, and the higher pressure air inside the lungs, air flows from high pressure to low. That means we squeeze and it flows out. Okay, moving on. All right, so let's see. We did that. Here we have our vertebra. Okay. Actually, it's easier to see the ribs. We have the ribs. The costal cartilages are these cartilages that go to other ribs instead of going directly to the breastbone. Up here we have the true ribs, where it's rib and cartilage and breastbone, also called sternum. Okay, Now, the sternum has different parts, which we call sternebrae. We have the manubrium here at the top and the xiphoid process at the bottom. The xiphoid process, anyway, it's at the bottom. And if someone uppercuts trying to get into your diaphragm, sometimes they hit and break the xiphoid process. Anyway, this body is actually made out of separate little bones called sternebrae, kind of like vertebrae, that will then fuse together. So the true ribs, you have the rib articulating with cartilage end that touches the sternum. The false ribs don't. They hook to other ribs. So you have cartilage, 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 all the way up there until it touches. Anyway, let's move on. So 12 pairs of ribs, all are connected directly to thoracic vertebra in the back. Each rib, it says the body and transverse process of the corresponding thoracic vertebra. That makes sense. It's at the back. They curve outward and then forward and downward. The true ribs are 1 to 7. They're the ones that connect directly to the sternum through a costal cartilage. The false ribs, 8 through 12, their cartilage connects to another rib. It doesn't connect directly. Floating ribs, 11 and 12, have no connection at all with the sternum. Let's go back to the picture. The floating ribs right down here, you can see they don't even have cartilage hooking them to the other false ribs. So, all right. And I want you to know, this gives some flexibility to the chest, a little bit of give. When you're younger, as you get older, it gets stiffer because you mineralize, you lay down calcium in the cartilage, and you fuse the sternebrae up together. I also want you to know that in other animals like whales, there's actually an articular joint here, cartilage, synovial fluid, the whole deal, on the side of the ribs. And part of that gives them their almost magical seeming ability to do deep dives and have a greatly reduced likelihood of getting the bends. Talk to me later, send me an email if you want all the details. This is human biology. We're moving on. All right, so the sternum or breastbone, it says along with the ribs, protects the heart and the lungs. The 3 main parts of the manubrium at the top, the xiphoid at the bottom, in between the body. I already told you that the body, there are actually individual little sternebrae that will fuse together. Anyway, the manubrium articulates with the clavicles, the collarbones. Your collarbones join with the manubrium at the top, all right? So we should go back to find a better picture, show that. Here's our axial skeleton picture. It's awful small, but you can see it. In white here, we have our collarbones, our clavicle that cross over and join with the manubrium. So, moving on. Did that. Okay. Yeah, so intervertebral discs, we did that. We must have missed this slide. I'm going to do it. So intervertebral discs, we were talking about how they absorb shock and everything. I got super excited about that. They get weaker with age and they can herniate or rupture. Remember, they're tough around the outside and more cushy, spongy in the middle. If they rupture and the inside squeezes out, then you can get pain because the discs push on the spinal cord or the spinal nerves that are coming out through those intervertebral foramen. So now we'll do this. Good. So, okay, manubrium articulates with clavicles, we did that. It joins with the body of the sternum at an angle. That's part of what gives us our shape here and our thorax. When we count the ribs, it's usually done to see where the point, the tip of the heart is located. It's usually between the 5th and the 6th vertebrae. The xiphoid process is an attachment for the diaphragm. The diaphragm is that muscular wall that separates your thorax from your abdomen. It's the muscle that moves up and down to cause breathing. It pushes on the lungs or it pulls away from the lungs. What happens is when this muscle, it's actually curved. I should have my hands upward. It's curved like this. When the muscle gets shorter, it also drops. And that, because of pleural fluid, we'll talk about it later, but because of fluid, when this pulls down, by surface tension, we pull down on the lungs above the diaphragm. The lungs follow, the lungs expand because they got bigger volume, air flows in. And then when we relax the diaphragm, it gets longer, which means that the stretchy lungs, they're not being pulled down anymore. They've returned to their natural shape. They pull up and you have reduced volume, more pressure, air flows out of the lungs. Anyway, that muscle, that diaphragm, attaches to the xiphoid process of the sternum in the middle there. All right, here is a check your progress. I'm gonna pause a second, let you make sure you can answer all those questions. If you can't, roll the video back and watch this section again. All right, let's move on. We did the axial skeleton, we're now doing the appendicular. If you think of an appendix in a book, that's the part that's kind of seems like it's added on at the end. Well, the same thing, we're adding on. We've got the main skeleton, the axial skeleton, and we're adding on what happens in the arms, what happens in the legs. That's the appendices. So that's the appendicular skeleton. All right, so we just like we have the pelvic girdle that we attach the pelvis to, we have the pectoral girdle that we attach things around the pectoral muscles here, the chest. Think chest when you hear pectoral, all right? So the pectoral girdle would be the scapula and the clavicle or collarbone. We're talking scapula is your shoulder blade and clavicle is your collarbone, all right? The clavicle joins with the sternum at a spot right over there called the acromion process. And the muscles of the arm and chest attach to the coracoid process on the scapula. Coracoid means, if you think of the word corvid, it's a crow. Corvids are crows, birds related to them. And the coracoid process is very, you have to use your imagination, but the people who were naming parts of bones thought it looked pointy, kind of like the beak of a raven, and that's where it got its name. Anyway, so it's the pointy bit. Let's jump ahead to a picture of the scapula. That's a really lame picture of a scapula. Yeah, okay. Looking closely, we have a clavicle. No, we're going to get a better picture than that. Hold on. Okay, this is a much better picture of a scapula. And the coracoid process is this little point right here that they said, oh, that looks like a bird beak. It's not nearly pointy enough, in my opinion. Now, there's also this huge one here, the acromion process. That's labeled 10 over here. That's actually the end of the spine of the scapula. So the scapula is flat bone. It has this raised ridge across it, and that's called a spine. And the tip of it is the acromion process. All right. If you look, the area above the spine is going to be the supraspinous, and the area below is going to be the infraspinous. Let's see, where do we have it? Yeah, so supraspinous fossa. Fossa just means a location, okay? So this area right here above the spine, supraspinous. This area below the spine, that's going to be an infraspinous. this surface right here, where the head of the humerus articulates, that's your glenoid fossa right there. This point right here, that's going to be at the top, so superior. So that's going to be your superior angle. And since you know the glenoid fossa is where the arm is, that means this side where the glenoid fossa is, that's lateral, this side is medial. That means this edge right here is going to be your lateral margin, and this is going to be your medial margin. Another way to think of it, the more vertical of those two margins, one's real sloped, diagonal, the other's closer to vertical. The vertical one is medial. Okay, and again, coracoid and acromion. The acromion is part of the spine. All right, let's go back to your book where they have the itty bitty weeny drawing, and we'll leave this lovely big drawing. Again, it's in Wiki, it's easy to find. You can look at these lovely Gray's Anatomy photos there. Okay, we're talking about the pectoral girdle. That's made out of the scapula and the clavicle. We just went over some of the features on the scapula. Let's move on. So, the pectoral girdle is mobile and unstable. Mobile because we have that ball and socket joint where the head of the femur goes in, and we can move it all around. Unstable because we can dislocate a shoulder. It can pop out of the glenoid fossa. The head of the humerus can come out of the glenoid fossa on the scapula. Anyway, so since we don't want that to happen, we have ligaments and tendons that hold it together. Remember, tendons tie muscles to bone, ligaments link bones together. Tendons that go from it says extends the humerus from 4 small muscles on the scapula. But if you have bigger circular movements, you can still overcome that. Still force it out of its little spot in the glenoid fossa. So, talking about the upper limb, the arm. The bone in the upper arm is the humerus, and this is one of those things where I like to tell people, learn the bones well, learn really well, because you'll see those same terms used again for regions of the body or for the names of blood vessels or the names of muscles. A good example of this, we're talking about the humerus, and there's a blood vessel that goes all the way around it, and it's called the circumflex humeral artery because it goes around the circumference. It literally goes around the humerus. So anyway, humerus, yeah, and if you look at your arm, you got 2 bones in the upper arm. Sorry, you have 2 bones in the antebrachium here. And 1 bone in the brachium. So humerus, 1 bone, and down here we have radius and ulna. The funny bone is the olecranon process of the ulna. So that's this part that sticks out in the back of the joint. Anyway, so the humerus is the single long bone in the arm. Rounded head that fits in the glenoid fossa of the scapula. You already heard that. The shaft of the humerus has a feature on it that I want you to know. It's called a tuberosity, a protuberance, where the deltoid muscle from the shoulder attaches. So the tuberosity on the shaft, deltoid, definitely know that one. The upper limb, continuing, the far end of the humerus has 2 protuberances, the capitulum and the trochlea, which articulate with the radius and the ulna. And the bump on the back, which I just talked about, that's your olecranon process. All right, so those are some bony landmarks to know.
the capitulum, the trochlea, the olecranon process, and the tuberosity. All right. The wrist bones are the carpal bones. All right. Not that you care, but that's what I actually looked at in my thesis. So we have metacarpal bones here. Metacarpal bones, 5 in the palm, and the metacarpal that is here, it's still a metacarpal, but we can separate it. These you don't have the ability to abduct, to pull away from each other. So metacarpal. Here, let's do it this way. Metacarpal. So metacarpal. Metacarpal that moves. The first section of the thumb is actually metacarpal. Actually, is metacarpal. Anyway, and your knuckles are the ends of your metacarpals. The phalanges are the bones of the digits. We use the same term for the finger bones and the toe bones. They're both a single bone. A single bone there would be a phalanx, and the more than one would be phalanges. Anyway. So we've talked about the pectoral girdle, the scapula, and the clavicle. And we've talked about how they articulate with the humerus. We've gone over some bony landmarks in the humerus. Now we're going to the pelvic girdle and the lower limbs. All right. The pelvic girdle has 2 coxal bones. Yeah. The pelvis is the pelvic girdle, the sacrum, the coxum. If we were going to break these down, what they're calling the pelvic girdle, the ilium are the ones that stick up on the top. The ischium are the ones on the bottom where you have the hole that goes through. And the pubis are the ones that stick forward and join at the pubic symphysis at the front. This bears all the weight of your body coming down on your leg bones. It's even more pronounced in the leg bones, but it's the same idea where you have a ball and socket joint, and the weight is coming down, and the head of the femur has to bear everything. Anyway, so bears the weight of the body, protects the organs. The pelvic cavity is the place that attaches to the legs. We already talked about that. Head of the femur. Actually, right there. So head of the femur here, and this little ring of bone, the socket, the cup-shaped socket that the head of the femur goes into, it has a name. It is the acetabulum. All right. So here, the ilium, the part that sticks up, the ischium, which is down below, has the hole in it, and then the part that comes around to the front is the pubis, and the 2 parts of the pubis fuse at the pubic symphysis. All right, so the femur, and the patella is a giant sesamoid bone. It's embedded in the combined tumor in the combined tendon of the 4 quadriceps muscles. Anyway, but we'll get into that. Moving on. So the pelvic girdle, we have a coxal bone, 3 parts: ilium, ischium, and pubis, which we just talked about. In an adult, those are fused together. The hip socket is the acetabulum, where those bones meet. The largest, the one that sticks up, is the ilium. The one that we sit on that sticks down is the ischium. At the back, there's a spine, the ischial spine, where muscles attach. Let's see. The 2 pubic bones join the pubic symphysis. I think we kind of said that stuff already, but let's move on. Pelvic girdle in male and female, they differ. The male pelvis is narrower. Female pelvis, the iliac bones, the ones at the top, they're flared, they're spread out. The pelvic cavity is shallower, and the outlet, the hole, is wider. What I'm saying is the ischiums in a male, they'd be like this, and in a female, they'd be wider. They'd be like that. They are more than 90 degrees. If you see more than 90 degrees, like, oh, this is a female skeleton. So those adaptations make it easier for a kid to be born. In the lower limb, we have the femur in the upper leg, and the tibia and the fibula in the lower leg. It's easy to remember fibula. Think of, oh, a little fib. It's not a real lie. It's a little fib, which is a false thing to say in itself. But since people act like a fib is just a little lie, it's easy to remember it's the littler bone, it's the thinner bone of the two that are there. The tibia is bigger, the fibula is smaller. Anyway, the femur is the biggest, strongest bone in the body. The head of the femur is what the ball that sits in the socket of the acetabulum. The neck of the femur is the narrow spot there just below the head. And the femur has two big processes on it, the greater and lesser trochanters, which are where we attach the butt muscles, the hip flexors. The distal end has medial and lateral condyles that articulate with the tibia. Wide head of tibia, a very narrow, tiny fibula. All right. The patella or kneecap, like I said, it's a giant sesamoid bone, so it's embedded in a tendon, the tendon of the quadriceps. Quadriceps, we'll get into this when we talk muscles, but you got four muscles that together we call the quadriceps. The easiest one of those to remember is the rectus femoris muscle, because it's straight down over the femur. Rectus means straight, and where is it? It's over the femur, rectus femoris. Anyway, those four muscles all go together. Their tendon, it becomes a common tendon. It goes over the knee, and it has a sesamoid bone in it that we call the patella. Okay, they're going to attach to the tibial tuberosity. At the bottom of the tibia, on the medial side, we have a malleolus. The fibula is the smaller bone, slender. The head articulates with the tibia. At the distal end, it has what we call the lateral malleolus. That's the bulge on the ankle, that little round thing on the side. Okay, yeah, let's move on. So like we had carpal bones for the wrist, the small bones in the ankle are called the tarsal. The biggest of those is the calcaneus, the one that sticks out the back and forms your heel. The talus is the one at the bottom that touches both the tibia and the fibula. And those two bones, the talus and the calcaneus, support our weight. Just like on the hand, we had metacarpals. Just like on the hand, we had metacarpals right here. The bones that are in the foot, the upper surface of the foot, are metatarsals. And again, the toe bones, the finger bones, they're all phalanxes. All right, moving on. Oh, it's a check your knowledge to go over the pelvic girdle, pectoral girdle, and how to tell gender. I'm going to pause for a moment. You can check yourself, see if you can answer these questions. If you can't, rewind the video, watch that part again. All right, let's move on. So let's talk about how they do, how they identify skeletal remains. Age, they can figure out by how the teeth are worn. how ossified the bones are. In a baby, they have less calcium, a lot more cartilage. Anyway, the condition of the joints often tells you about age. Older people tend to have eroded joints. For gender, you can use the pelvic bone, where it says the thickness of the long bones or skull characteristics may be used. If the pelvis is all destroyed, you look at other things. Men tend to have thicker, denser bones. And skull characteristics, the zygomatic arc here, zygomaticus bone, that tends to be a little wider in men. Ethnicity is hard to tell from the skeleton, but people who do facial reconstruction, they can go and look at individual points on the skull and have very minute little tiny measurements. They're very careful. This is based on comparing lots and lots of different skulls from lots and lots of different kind of people, and they can determine ethnic characteristics. They can do facial reconstruction pretty well. That's way beyond my level of knowledge about skull anatomy. All right, so we'll go over types of joints, and we got to talk about things like synarthry. We're going to talk about things like gliding joints and saddle joints and ball and socket joints. You've heard me mention multiple times the head of the humerus, the head of the femur being ball and socket. And we'll talk about the types of movements that they can make. And a synovial joint, you actually have a capsule where the articular cartilages come together. There's a capsule around that to keep this synovial fluid in, and then you have the synovial fluid. It lubricates that joint and allows it to move, but we'll get into it. All right. Where bones come together, we have fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints, they don't move much at all. So sutures between the cranial bones, kind of like here we have the sagittal suture, and here we have the coronal suture. And then we have on the back, we got the lambdoidal suture. Those sutures, you have the bones hooked together by all kinds of fibrous connective tissue stuff, and their pieces are, it's not like a straight line, it's all wiggly, 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 kind of like they in woodworking. If you dovetail, if you don't want the two things moving, they stick together like that, kind of like jigsaw puzzle. That's what sutures are like. They don't move. Cartilaginous joints, connected by hyaline cartilage at the ribs, or fibrocartilage at the intervertebral discs. They've got some movement, but not a lot. Synovial joints are the ones with the joint capsule and the lubricating fluid inside. Those move really well. All right, so you got ligaments there to support the joints, strengthen them. What we're saying is ligaments link bones together. They are long enough to allow the movement of the joint, but they are not so long that the bones can come apart. At least that's the plan, without extreme amounts of force. Anyway, joint capsules are made by ligaments, surround the joint. They're filled with synovial fluid, which lubricates it. We talked about that before. You sometimes have bursa, which are little pillows made out of water. Basically, they're not water. They're full of fluid, and they are connective tissue around the outside. And they cushion, and because they're smooth on the outside, you can rub on the bursa instead of bone on bone. It reduces friction. In the knee, we've got the meniscus. They're fibrocartilage that absorbs shock, gives stability. Anyway, so here we have Some synovial joints. We have the one in the elbow here, where we have the ulna and the olecranon process of the ulna. Here we have the humerus. Okay, so this whole thing where the bone articulates, so the bones rub together, that's a hinge joint, okay? And it is going to be enclosed in a joint capsule that's full of synovial fluid to lubricate it, make it move. Here we have a ball and socket joint. That's the glenoid fossa of the scapula and the head of the humerus. Again, we've got tendons of muscles that attach to the scapula and then go and attach here on the tubercles. And those are going to hold the head of the humerus into the glenoid fossa, hold them up against each other, and all those tendons grow together, form the capsule that keeps the lubricating fluid inside. The knee has the meniscus. This is, they've drawn in I thought they were doing it in purple, but they're doing that as the joint capsule. They're putting the meniscus right below it in a gray. I wish it was a greater contrast in color. Anyway, that's fibrocartilage. That's tough. That's shock absorbing. So if you're jogging or something, you don't bust the tibia, because this is tibia down here. Anyway, the capsule is formed by ligaments. They're linking the muscles to the bone. Linking the bones together. Here we have the bursa, the little fluid-filled cushions. Like, what are they cushioning there? The movement of the tendon, the movement of the patella. We're trying to keep them from rubbing on the bottom of the humerus. All right, so there we go. So types of synovial joints. We have ball and socket joints. They can move in all different directions. You can do rotational movement. We got those in the hips and shoulder. Hinge joints, elbow and knee, only move in one direction. So let's talk about movements, types of movements you can make. In general, now there is an exception in the way that we name movements of the foot. But in general, if you are taking a thing away, you are abducting it. If you are bringing it closer to the body, you are adducting it. So if the leg is moving away from the midline, it's being abducted. If it's being pulled towards the midline, it's adducted. Same thing with the arm. All right, if you are increasing a joint angle, we call it flexing. If you are, I said increasing, decreasing. If you are decreasing the angle, you are flexing. If you are increasing the angle, you are extending. And like I said, they reverse that in the foot. They call the foot differently. Yeah, so here is, I'm going to move that back. Here is my arm, my elbow. If I am decreasing the angle, that's flexion. If I am increasing the angle, see, say I'm here and I'm at 90 degrees, and I'm going to go to 180 degrees, that's extension. Just think like you have a protractor, straight line 180, 90, okay? So if I go from 90 to a 45-degree angle, that is flexion. If I go from 45 to 90, that is extension. All right. Inversion is the ability to turn that foot in towards the midline, or eversion would be the ability to turn it out. So if the palm, the bottom of your foot, comes towards the midline, that's inversion. If the palm is pushed out towards laterally, I said palm, plantar surface. The bottom of the foot's the plantar surface. The hand here is palmar, which is what I was showing you. The foot is plantar. But if you're taking the plantar surface, the bottom of the foot, and moving it towards the midline, that's inversion. If you're taking the bottom of the foot and moving it outward laterally, that is eversion, everting. Okay, so this is a check your progress, talk about the types of joints. I'm going to give you a second to review this. If you need to go back and listen to the thing again, you can pause it. That made no sense. You can stop it, rewind it, watch it again. Now I'll stop. All right, let's move on. So let's talk about science. Osteoarthritis is when your cartilage is breaking down. Rheumatoid arthritis, autoimmune disease, it causes inflammation in the joints. These are things that might require joint replacement. So rheumatoid arthritis is an autoimmune disease. That's a fancy way of saying your body, for reasons that are probably unknown, there could be more than one reason, has decided to attack and destroy the joints, destroy your own body. And people who have this probably have other autoimmune disorders too. It might be Crohn's disease, it might be Sjogren's, it might be lupus, it might be type 1 diabetes. All of those are caused by the immune system going crazy and attacking itself. All right, so we're going to talk about growth and homeostasis. Remember, homeostasis is maintaining internal body conditions at a relatively constant level. Our goal is to keep things here. Now, most of that's done with negative feedback loops, which means in reality, you're going to go up a little, you're going to go down a little, you're going to go up a little, you're going to go down a little, but you're wavering around this ideal you want to stay at. A lot of books illustrate this as a seesaw that, oh, we're going to raise the body temperature. Oh, no, 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 we're going to lower the body temperature. Oh, we're going to raise the temperature. Oh, no, we're going to lower the temperature. But what's happening is that you're tracking around a constant body temperature. It might be going a little up, it might be going a little down. All right, so we're going to talk about how you ossify bone and list the types of cells that are involved, talk about bone remodeling, and how to repair a bone. The big things here that we're going to talk about are osteocytes, osteoclasts, osteoblasts, osteogenic cells. It's simple. The osteogenic cells, those are the stem cells that can become anything else. An osteoblast is a baby bone. The B should remind you of baby, a baby bone cell, okay, baby cell. But the important thing to remember is that blast, osteoblast, that B is because it is a bone builder. The osteoblast builds the matrix, the substance that will be filled with calcium. The osteoclast, the C should remind you that it cuts bones. A lot of time when I'm talking to students face to face, I use my fingers like a pair of scissors when I say osteoclast to remind them it's a bone cutter. This breaks down existing bone. In remodeling bone, what we're going to do is constantly be taking bone away with the osteoclast and replacing with osteoblast. What that does is prevent you from having like little microfractures that will eventually become bigger, become bigger, become bigger. What we do is just replace the bone with new bone. Anyway, let's move on. Let's jump into it. So osteoblasts, the B should remind you that they are bone builders. Okay, they make the organic matrix of the bone, and that matrix is where we're going to deposit calcium and phosphate to form the hydroxyapatite, the mineral, the bone. When you think of bones, you think this tough calcium-filled stuff. That's the hydroxyapatite part of the bone. Bones obviously also have blood supplies, they have nerves, they have these living cells that we're about to talk about. So the osteoblasts are babies. They're going to grow up to be osteocytes. Okay. Osteocytes are living cells that are in the matrix, but they're in little spots called lacunae, mini lakes. And you know how lakes are sometimes connected by canals? Same thing. The lacunae, the little lakes, they're connected by canaliculi. And the osteocytes actually hooked to each other, and they can transmit chemicals to each other, nutrients to each other, stuff like that. Anyway, so osteoblasts build bone. Osteocytes are not doing that anymore. You might say, why do we still have them? Well, they're there to detect stress on the bone. Okay, then we have osteoclasts, which are bone cutters. They break down the bone. They do this with enzymes. They do this by releasing hydrogen ions, making it acidic. So the calcium is released from the hydroxyapatite and it can be reabsorbed by the osteoclasts. So through your whole life, the clasts are going to cut bone down, the blasts are going to build new bone. Ossification it means to become bone, okay? Because you start out with cartilage where you're going to have a bone. Not entirely true. Let's try that again. Most of your bones, all your long bones, you're going to start out with a cartilage model of the bone, and then you're going to replace it with bone. Okay. And understand it's not just, oh, it's cartilage and then we mineralize it. No, it's actually replaced. We'll move on. Okay. So there are two ways to do making of new bone. Intermembranous ossification and endochondral ossification. Endo means inside. So endochondral is in the cartilage. You're doing this in the cartilage, the little cartilage model. Intermembranous is in the membrane, okay? So if we hadn't talked about it yet, around a bone, you have the periosteum membrane, and inside the bone, lining the marrow cavity, say if you're a bone that has a marrow cavity, you have the endochondrium. So those membranes have cells, like they have osteoblasts in them. Those osteoblasts can make bones. You can make the bone thicker, thicker, thicker by adding from the sides because you have the periosteum around it. And the periosteum is actually what your tendons attach to. Anyway, we'll move on. So intermembranous bone forms the flat bones, like the bones of the skull. You have these sheets of membrane that contain the fibrous connective tissue and osteoblasts that will build the bone, okay? So osteoblasts that are part of the periosteum will carry out ossification. They will help to build the bone. The trabecula will fuse into compact bone, which surrounds spongy bone inside. What they're saying is if you look at a bone in the skull, it is compact bone, it's like a little sandwich, compact bone, spongy bone, a very thin little sandwich, but that's what it is. And so you have fibrous connective tissue membrane, and they make compact bone, but between them is fibrous bone. Endochondral, this is what you have in the long bones usually. We have a hyaline cartilage model of the bone, and where it says calcified bone matrix replaces the hyaline cartilage models. Or understand, we're going to break down the hyaline cartilage and replace it with bone matrix. It's not that we just pump some calcium ions into the cartilage. It's possible to ossify cartilage, but it's possible to mineralize cartilage, but mineralized cartilage is still not bone. And bone formation goes from the center of the bone to the ends of the bone. True, but it would be more accurate to say you're going to have a primary ossification center in the diaphysis, in the shaft of that long bone. And then you'll form secondary ossification centers in the proximal and distal ends. We call those ends epiphyses. And actually, there's a line of cartilage between the epiphyses and the diaphysis. And those two lines of cartilage, hyaline cartilage, those are the growth plates, the epiphyseal growth plates. And like a child can grow taller because their bones are getting longer. How is that happening? The hyaline cartilage is dividing and producing more cartilage model. So you're making new cartilage that pushes this forming bone longer. And then you are, at the same time, you have the replacement of that cartilage with bone. So we have the cartilage growth plate growing the bone longer and growing the future bone longer. And then we have replacing that cartilage with bone tissue. There's a race between the two processes. And whenever you use up, whenever the making of the bone tissue, replacing of the cartilage, goes faster than the making of the cartilage, you're going to close the growth plate. When they close and you have nothing but bone, you're done getting taller. Anyway, but we'll move on. So here we have a cartilage model, and here we have chondrocytes, cartilage cells in the lacunae. You can see the diaphysis is the middle, the epiphyses are on the ends. Cartilage, remember, doesn't have much blood flow, almost none. So when the blood vessels penetrate, you're going to start making bone there. Blood vessels penetrate, and they can bring all the minerals that you need, and they can bring the bone-building cells, the osteoblasts. This starts at a primary ossification center, and they are replacing the cartilage with bone tissue. The osteoblasts are building bone. Now, the secondary tissue, or the secondary ossification centers, are going to be in the epiphyses. You can see them right here. Anyway, so we penetrate, we break down the cartilage, replace it with spongy bone. Then as we keep going, we are going to hollow out this middle area and keep adding bone along the outside. What you end up in the diaphysis is a hollow medullary cavity and then compact bone around it. On the ends, the epiphyses, you're going to stay spongy bone. Okay, so spongy bone with a little compact around it. Remember, just like your skull had thin layer compact bone, thin layer compact, spongy in the middle. Well, the end, the epiphysis of the long bone, it has compact bone around the outside, spongy underneath it. And that's going to be where you tend to have red marrow, tend to continue making blood cells there. In an adult, at least, the diaphysis, that hollow marrow cavity in the middle, is probably going to get filled with yellow marrow, which is a lot of fat and almost none of the bone cell, blood cell making. Anyway, let's move on. On the top, outside the compact bone on the epiphysis, you have the articular cartilage because it's going to rub against other bones. All right, endochondral ossification. This is steps in what you just saw in the pretty picture. So as an embryo, you have a hyaline cartilage model where there's going to be a bone. It's shaped like the bone that's going to develop there. And the bone collar, I'm talking about the periosteum, okay? The osteoblasts that are in that membrane, they are going to build bone matrix. And that bone matrix will then get filled with the calcium and the phosphate to make the hydroxyapatite. So you get a collar. You'll still have a cartilage model, but it will have around it a little collar of bone on the diaphysis. Then you're going to form a primary ossification center. Blood vessels will penetrate and go into the middle of this cartilage model, and they will start to supply nutrients, minerals, and osteoblasts, bone building cells. That's going to happen at the primary ossification center. Eventually, the the medullary cavity is going to form, but spongy bone in the diaphysis. So you replace everything with spongy bone, and then you have osteoclasts, which cut bone, come in, and they break down the um, the middle of the spongy bone, and so you're forming compact bone around in the collar, and you're breaking down the spongy to leave a hollow marrow cavity, um, a medullary cavity, and this continues until you've made your diaphysis. Shortly after you're born, the ends of the cartilage model, the epiphyses, get their own ossification centers, and those are the secondary. We form the primary first, form the secondary after that. No big deal. Makes sense. The epiphyseal growth plate, we talked about that. Band of cartilage between the primary and the secondary. Okay, in between you've got a band of cartilage. Your limb bones are going to keep getting longer as long as you've got epiphyseal plates. When the when the bone is ossifying faster than the cartilage is being made, you're going to run out of cartilage. What that means is as you get older, the growth plates close. And once you've replaced it all with bone and you just have the epiphyseal line, you've stopped growing. And let's move on. Yes, you are an adorable dog. Show the world how adorable you are. Yes, okay, moving on. So the epiphyseal plate has 4 layers. We have a resting zone where there's cartilage but not much is happening. A proliferating zone where the chondrocytes, the cartilage cells, are making new cartilage. A degenerative zone where those cartilage cells are dying out. And an ossification zone where we are doing the replacing. We are replacing the cartilage with bone. All right, so here we have a nice drawing of an epiphyseal plate. We have the epiphysis at the top. So what you're seeing right here, they basically took and blew up this, this little thin blue band is blown up to be huge. What you see right here where it says epiphysis at the top, it's this spot here where we have the spongy bone, okay? The resting zone is close to the epiphysis. We have cartilage there, but we're not doing anything with it too much. Below that, the proliferating zone, which is where you have the expansion, that's where the new cartilage is being made. Below that, the degenerating zone, which is where the chondrocytes are dying. And then the ossification zone, where we have the osteoblasts coming in and replacing this with matrix. Basically, what we're saying is that these growth plates, they are not, here's a growth plate. It's not growing this way. The growth plate is growing this way, growing the bone longer. So you're making new cartilage, yes, that is up. I guess what I should say is you make new cartilage and then you turn it into bone. You make new cartilage and you turn it into bone. You make new cartilage and you turn it into bone. And guess what? Your bone just got longer. Okay, moving on. So the final size of the boats, when your plate's closed, the bone is as long as it's going to get. Things that affect how well you can grow a bone, how well you can maintain bone density, how much vitamin D you have. Vitamin D affects your ability to pick up calcium from your food. Growth hormone is going to affect how much of this activity you have with a thyroid hormone. Same thing. Hormones control the cells and signals to the cells. And sex hormones. You may say, what? about sex hormones? Remember we said before that male bones tend to be a little denser. It's because they tend to have a little bit bigger muscles attached to them. And so there's more stress pulling on the bone. You would probably want to toughen up the bone if you think you might have bigger muscles attached to it. So androgens, like for example testosterone, but male hormones are androgens. They will promote bone density. Okay, so vitamin D. If we're out in the sun, we get vitamin D, and our skin makes vitamin D from precursors. And hooray, we now have the ability to absorb calcium. Except now a lot of people spend all their time indoors. We don't get as much sun as we used to. And also, oh crud, there's possible skin cancer. So people tend to avoid being outdoors. And what that means is we need to add vitamin D. If you look at your milk that you drink, it probably says fortified with vitamin D or vitamin D added. It's so that you can use the calcium, absorb the calcium in that milk. So vitamin D is necessary to absorb calcium. And if you have low levels of vitamin D when you're a kid, your bones can be really weak because they don't have enough minerals in them. And so the weight of you standing on your leg bones can cause them to bend like that. And then they might finish ossifying that way with bowed legs, bent legs. You get bone deformed. Basically, if you don't get enough vitamin D, you risk getting bone deformities, and we call that rickets. Moving on. So growth hormone is going to stimulate bone growth. It also happens with thyroid hormone that stimulates your metabolism. Okay. You need both of those doing the thing. Dwarfism is caused by not having enough growth hormone when you're a kid. Gigantism caused by having too much growth hormone when you're a kid. Acromegaly would be having too much growth hormone as an adult. That's going to cause excessive growth of bones in the hands and face. Why not the legs? Because you already closed the growth plates. Sex hormones are going to increase the activity of bone formation in adolescence. Now, bone remodeling, we talked about this before. The osteoclasts are going to break the bone down. The osteoblasts are going to build it up. About 18% of your skeleton gets replaced, recycled every year. Paget's disease, new bone generated faster than normal, but not generated in the right way. Think of it as you don't spend as much time as you should. You're going to get softer, weaker bones. And what this means is that you will have bone deformities. The weak bones, they can be compressed and sag. And that can pinch nerves that are in them and cause pain. Calcium homeostasis. If your blood calcium level goes up, some of the excess calcium gets stored in your bones. If the blood calcium goes down, calcium will be removed from the bones to bring it up to normal. Parathyroid hormone does this. If you have too much parathyroid hormone, you are going to leach calcium out of your bones, put it in the blood more than you should, and it can cause things like early osteoporosis. But we can talk about that later. Oh, and there it is on the next slide. So parathyroid hormone stimulates the osteoclast to dissolve bone, promotes calcium reabsorption in the small intestine and kidney, increasing blood calcium level. Basically, parathyroid hormone is trying to keep the blood calcium level up. And if it has to screw up your bones to do it, it will. Because you need this, you need calcium for things like muscle contraction, you know. And you know that you need to have vitamin D to absorb calcium from your food. In your digestive tract, we already talked about that. I do want to point out with the parathyroid hormone, we have 4 little parathyroid glands. And like if you get a tumor in one of those and it gets too big, it could be releasing too much parathyroid hormone. We're lucky because we have 3 other glands. They could just take that one out. Anyway, moving on. Calcitonin is the opposite of parathyroid hormone. They're both hormones, but they work in the opposite way. Calcitonin is going to promote putting the calcium into the bone because it's going to cause you to say, oh, we got enough calcium in the blood, stop. Estrogen will increase the number of osteoblasts and the bone building cells. And when women get older and go through menopause, reduced estrogen, they don't have as many osteoblasts, as many bone builders. And that means that they're going to have trouble building bone. The osteoclasts are still there doing their job, so you may end up with weakened porous bone. Osteoporosis literally means bone with pores in it, bone with holes. So osteoporosis, the bones are weakened, they have less bone mass. Your bone mass is going to increase up until about age 30, and from 30 to 50, the adding to the bone and taking away from the bone is going to be about the same. After age 50, you tend to reabsorb bone more faster than you're forming it. The amount of bone that you have goes down. Risk factors of osteoporosis. Being female, being white or Asian, being thin, having a family history of osteoporosis, having early menopause, smoking and diet that doesn't have enough calcium in it. Basically, if you want to fight osteoporosis, get a lot of calcium in your diet, get a lot of vitamin D so you can absorb that calcium, and resistance, like low weight, high rep weight work. So you put a little bit of minor strain on the bone, enough to stimulate what's left of the osteoblasts to do their job better. Anyway, too much caffeine, too much alcohol, and then this big one, a sedentary lifestyle. If you're sitting around, you're not stressing the bone, your body doesn't feel the need to maintain it. If you are out walking or jogging, if you are lifting small weights, those things are going to help you. You're going to stress the bones and cause you to then want to strengthen the bones. So your osteoblasts that are left will do their job. All right, so here's an example. You look at normal spongy bone and you see the trabecula and they're nice and thick. And then you look at a bone with osteoporosis and so much bone has been reabsorbed that the trabecula are barely there. That's some weak bone. All right, so let's move on. All right, so let's talk about how to repair a bone. You're going to form a hematoma. Hema means blood. You basically form a blood clot. So we've got a bone, and this bone has a fracture. There's probably a pretty picture coming up. But we have a fracture, and we're going to flood blood to the area. This especially works well if you haven't torn your periosteum too much. You can like swell the area with blood. Yeah, there's a nice picture. Okay, so we have the periosteum, and that one actually does show a little bit of a tear, but we filled the area with blood. That's your hematoma. And fibrocartilage callus. You start by growing a bunch of collagen fibers and fibers in general to knit the two ends of the bone together so they're not moving around. You're not making bone at that point. You're just trying to keep them together so you can grow the bone between them. Okay, that's 3 weeks or so to grow the fibers to hold the pieces, hold the ends aligned. A bony callus, that'll take 3 to 4 months. You're going to grow cartilage. Basically, what we're saying is first you form the hematoma, then you form the fibrocartilage callus where all the fibers are holding it together. fibers and cartilage. Then you're going to replace that with bone. But it's going to be spongy bone, it's going to be weak bone. It's not going to be the great stuff that you want. Then you're going to have osteoclasts break that down. Osteoblasts replace that with nice dense bone. So when you initially repair it, it's going to be this spongy bone, and then you want to replace it with nice compact bone. And you can see the compact bone is a little bit thicker right here at the site where you were where you had the break. So the idea is your body's like, oh, if you're going to break there, we're going to try to make that strong. Now, unfortunately, bone healing works a lot better when you are young. Older people who tend to fall and break bones, it's really hard for them to heal because they have less of the osteoblasts. All right, so let's talk about types of bone breaks. You could have a complete break that goes all the way through, an incomplete which doesn't. You're not breaking bone into two parts. A simple break doesn't have like a bone sticking out through the skin. A compound fracture, that's the really ugly, nasty one where you see the bone sticking out of the skin. If it's impacted, you broke it and shoved the ends together. This would be usually from a compression problem. A spiral break, if you were twisting that bone, like an athletic injury, a spiral break, and that has a long surface area that's messed up, a larger piece of the bone. Bone marrow, we got two different types of bone marrow. We have yellow marrow, red marrow. Fat is stored in the yellow marrow, and so like predators, like a hyena, they love to break open the bones of the whatever has been killed. And I say that because usually it'd be like the lion kills the prey and the hyenas steal the prey. But they love to they have really strong jaws. They love to get to the yellow marrow because full of fat, lots of energy. Hold on a sec. Okay, I'm back. I just went out because I'd been talking about hyenas eating the marrow, and I just wanted to pull up a video. I'll try to remember to include in the links below. It's of a bird called a lammergeier that has a really clever way to find and eat yellow bone marrow. This is the only bird we know that its primary diet would be marrow. Anyway, moving on. Weird predators, that's not what we're here to talk about. Red bone marrow is where you make blood cells. Easy to remember because blood, red. Okay, yeah, moving on. So we will talk about how bone, oh, this is a check your progress. We did these things. I will, at this point, be quiet for a moment, and you can see if you can answer those questions. If you can't, rewind the video, watch the last section. Oh, and that's the end. We are actually done with this. So I will leave you now, and we will continue later with another chapter.